Okay, good afternoon, everyone, and thanks so much for joining us today for our Leaders Initiative Seminar Series. Our speaker is Dr. Annalise Rahman-Filipiak. Dr. Rahman-Filipiak is an assistant professor in the Department of Psychiatry at the University of Michigan. Her research interests include neuropsychological feedback and biomarker-based dementia risk disclosure, metacognition, and non-pharmacological interventions for cognitive decline. And with that, welcome Dr. Rahman-Filipiak.
Thanks so much, Courtney, and thanks everyone for being here. I'm very excited to be part of this series, and I know you've done a lot of work to get it up and going. So today I'm going to be talking a little bit about some of the research that I've done since I started here as faculty in 2018. Much of this work was done in close partnership with the research program on cognition and neuromodulation-based interventions and with Alzheimer's Disease Center. So I want to first and foremost acknowledge both of them as they really have supported me in this early career period. Nothing to disclose. So I want to start by setting the stage and just talking about some of the practical challenges as well as the benefits of returning individualized research results back to our participants. I recognize that many of you have probably seen this survey or this table before, but this was actually a paper that was published by our own Scott Roberts and colleagues as part of the advisory group on risk evidence education in dementia, or AGREED group. They surveyed the Alzheimer's Disease Research Network and really tried to discover what types of research results were being released back to participants. And what you can see here is that most centers do disclose some level of cognitive test results or research diagnosis, so the diagnosis that we give them at consensus. Many fewer centers release amyloid PET results and even fewer tau imaging results. And I think that's for a variety of reasons. I want to start by talking about some of those practical challenges. The first is money. We know that a lot of the work that we do is guided by our budgets, and it is extremely expensive not only to do that kind of imaging or testing, but also the disclosure process requires significant resources that are often not budgeted for in these kind of early phases of centers or grants. Also comes with extreme, not extreme, but significant time needs. It's not as simple as giving someone a phone call and providing some basic results. We're also talking about pre-disclosure education, about risk assessment, follow-up, et cetera. You know that there are many, many demands on our time. I think, those of you who are early career, we also are still trying to establish those different priorities. And no matter what career stage or where you come from, we are human beings. We have many, many different tasks to oversee. There's also the note that disclosure is rarely the focus of these grants, at least when they were initially written and funded. Often there are other primary outcomes or goals of the grants that need to be met, and therefore disclosure is often seen as a bit of an afterthought. And finally, there really aren't too many people who have expertise in communicating these results. We know that things like genetic counseling, there's a lot of training available for that. There are some guidelines available. That's not necessarily true when we think about other types of Alzheimer's disease biomarkers like PET imaging or some of the newer blood-based biomarkers. I'm not going to go into these in detail, but I want to note that there are also significant practical challenges for each type of information that we disclose. So for neuropsychological data, for structural neuroimaging, but also for biomarker data, there are some specific challenges that I think make it even more challenging to share that information back with participants. Many of them revolve around the great heterogeneity of how these data are collected, how they are analyzed, how they are interpreted, and some of the ambiguity that comes with that interpretation. I want to note that one major issue in this particular field, so the field of biomarker development, validation, and communication, is, as with other aspects of the Alzheimer's disease field, a lack of racial ethnic minority representation in these studies. So there's the question of whether these biomarkers are equally meaningful at the same cut points, what they can and cannot predict, and who the normative sample really are. Those of you who attended the spring ADRC meeting last year might have seen this slide before, but I do just want to note some of the practical challenges with communicating biomarker results and why that is very different than, say, neuropsychological test feedback. First, when we're communicating biomarker results, we're talking about etiology, so what's causing a person's cognitive difficulties, not necessarily their phenotype, their actual clinical diagnosis. And that's something that's really hard to communicate clearly to participants, especially those who may have some level of cognitive impairment. Similarly, we're drawing a really clear line here. Our service here is really in a research capacity. It is not a clinical diagnosis or a clinical service. And so there are some parameters that we have placed around the work that we do that are different than those faced when we're seeing patients in clinic. We're also talking about dynamic biomarkers. Unlike genetic information, these biomarkers, like your PET amyloid scan, they're changing over time. And so telling someone that they are currently not elevated does not mean that you are telling them they are permanently not elevated. And while generally we think that is good news to share with someone, that can sometimes get lost as part of the messaging. We also can't comment on prognosis. So having an elevated result does not necessarily mean that we can predict a definitive dementia prognosis or diagnosis. We don't know what the trajectory of decline might be. Many of our participants in our biomarker disclosure studies, their first question is, how many good years am I going to have? And that's not a question that I can answer based on an amyloid scan or a tau scan. We also have to be careful about what we're commenting on in terms of the contribution to the clinical picture. Having an elevated amyloid result, for instance, may help us rule in or have more confidence about Alzheimer's disease as a potential underlying pathology, but it doesn't allow us to rule in or rule out other contributors, some of which may be more readily modified. So it's important when you're communicating this information to not focus solely on that one piece of information we have to share. So now that I've convinced you that it's hard, I hope to also convince you that it is important and that it's worth pursuing. So of the many benefits of sharing this information back with participants, the first is the consideration that having this information could even be seen as a participant right. There is a movement in part sponsored or carried by a recent participant Bill of Rights that was published by Sarah Walter and her team. They're also part of that agreed advisory group, with the idea being that participants have the right to receive as much information as they can from their research participation. It's also true that participants have the right to not know if they don't want this information, and those are things we have to balance. One potentially more compelling reason is that this information could be motivating for meaningful change, regardless of what the result is. Studies like the IDEA study have shown that having biomarker results allows physicians to be more confident in their diagnosis and their treatment plan, their monitoring plan, et cetera. And we know from Reveal Scan and other studies that this information is meaningful to the participant themselves and their family members. Individuals who receive an elevated amyloid result, for instance, note that they are more invested in engaging in health behaviors like diet and exercise, as well as advanced planning, things like choosing a decision maker, considering where you might live, purchasing long-term care insurance. We also know from our own studies that it may allow care partners to become more prepared for their role in the future. It's actually the topic of one of the dissertations that we're working with. Scott Roberts and myself have a really wonderful student, Sarah Feldman, that's looking at exactly that issue. I want to share a note here too, and this is a study that was published by Jennifer Lingler and colleagues at Pitt. They did a really great study looking at reasons for engaging in Alzheimer's disease studies among their cohort. They found that participants really listed two categories of reasons for engaging in Alzheimer's disease research. The first is perhaps what we would think. So what we talk about in our consent form, there's some benefit to the science or benefit to humanity as a whole. But there's also a whole list of reasons that are much more personalized, including gaining access to treatments, which is something I think that we'll see even more frequently with aducanumab and lecanemab coming out, but also to learn more about one's own health and having access to clinical care. Interestingly, in this study, they also looked at demographic or personal factors that might predict an individual's desire to engage in Alzheimer's disease research through the pathways of these potential reasons. And what they found was that participants who had cognitive impairment emphasized those more personal reasons over the altruistic reasons. That makes sense. If you have cognitive impairment, you may be more motivated to find out, to engage in this research, hopefully to advance the cause, but also to learn more about where you stand. They also found that Black participants, and to a lesser extent, Asian participants, were significantly more likely to emphasize those altruistic reasons. And that could be for a variety of reasons, including a lower access to healthcare and some of the health disparities that we know exist for those populations. In this study, they took it one step further. They looked at some of the barriers to engaging in research participation, and they found that for Black participants, they were more likely to worry about things like a HIPAA violation, so basically a privacy violation. And that was a major barrier to them engaging in Alzheimer's disease research. But what they found was that trust in the medical researchers mediated that relationship. One way to potentially target trust and also kind of value or emphasize some of the personal parts of engaging in research is through potentially disclosing results. So this may be one way to not only drive up retention and recruitment for all of our participants, but maybe even differentially so for those of minoritized racial ethnic backgrounds. So now I want to shift gears a little bit away from the practical and think more about some of the ethical and cultural considerations for the return of results. Everybody at this point is probably pretty familiar with these curves. So these are the Cliff-Jack curves. I want to note that as a neuropsychologist, my interactions with participants often come at the point at which they are being given a clinical or phenotypic diagnosis, because that's when they arrive in my office for testing, because they have concerns. But these biomarkers, things like PET, CSF, as well as some of the more novel blood-based biomarkers, are really allowing us to identify folks much earlier, potentially increasing or opening that window for intervention. But at this point, we still don't really share biomarker information consistently back with our participants. And that's for a range of ethical considerations in the absence of best practice guidelines. Some of the ethical considerations include this right to know versus the desire not to know. Who do we share this information with? Who needs the information the most? Who is most susceptible to risks associated with this information? There's also this balance that we all play as clinical researchers and clinicians, which is this balance between do no harm and also do as much good as possible for the people that we serve. That makes us question whether biomarker disclosure is safe and for whom and under what conditions, and also whether the participants that we hope to serve will truly benefit from the information by understanding it first. Another consideration is this protection against risks versus respect for autonomy. We're talking about disclosing results to individuals who may be cognitively symptomatic and therefore may have difficulty demonstrating decisional capacity or really understanding what their personal level risks and benefits might be. And then finally, it's very important to always consider aspects of cultural diversity. We need to know whether risk disclosure needs differ across the groups that we hope to serve and how social determinants of health may impact an individual's ability to use this information adaptively moving forward. So this is really, this is sort of a map of my own work. And I remember writing this out when I was a postdoc and thinking about how do I go about addressing some of these questions. So I hope to present some data in the rest of this presentation that begin to speak to some of these questions. The first question that we really placed as foremost was taking a community engaged or community-based participatory research aspect. How do we go about knowing whether participants and their families actually want to know their results? So before we get into how do we do it, is there a need to do it? So the way that we addressed this was through an RO3 in which it was really separated into two phases. The first phase was a needs assessment with 50 dyads who were either Black or African American or identified as white. And the dyads included participants who were either cognitively normal or had early cognitive changes, so had a diagnosis of mild cognitive impairment. The care partner, so the other part of the dyad, was the individual who was currently caring for or assisting the participant or would be that person in the future. Now, these were all participants who were either eligible to receive a PET scan or had already completed a PET scan. So we recognize that it is a sample who is already quite motivated. The first question that we asked as part of this sort of study, so we did a mixed method study, but we did include some questionnaires here. I haven't included all the questions. We essentially asked participants how much they wanted to know their cognitive test results, their MRI results, their genetic information. But what I have depicted here is the data on how participants really felt about knowing their amyloid and tau PET results. Now, what you can see here is actually a trend that we saw for all pieces of information. We see that participants are highly invested, highly interested in learning their PET biomarker results, and that was regardless of race or diagnosis, which is what we also looked at. We also see that care partners or co-participants are very interested, but maybe slightly less so than their participants, their respective participants. And we did see a significant effect of race, such that white care partners were more interested in knowing this information than their Black counterparts. The next step of this was doing a semi-structured interview in which we asked participants about why they personally might want to know or not want to know their results. We did this first by saying, open-ended question, tell us why you might want to know your PET biomarker results. What are some of the benefits for you? We then gave them a list of benefits that we drew from the literature using concept mapping. We asked them to endorse any benefits that they felt were relevant for themselves. And lastly, we asked them, okay, so what is the primary benefit? What is the main reason why you personally want to know this information? And that's what I have depicted here. So you can see participants are on the left, co-participants are on the right. Now, while we did see some reasons that we expected to see, many folks are interested in engaging in treatments or clinical trials and forming long-term care plans. What I really want to point out here is the diversity of responses that we got. That primary reason really differed amongst our samples, and that was true for both participants and care partners. Additionally, we didn't always see agreement between what the participant felt they wanted the information for and why the co-participant wanted the information. And this, to me, really points to the need for some tailoring or flexibility built into our biomarker disclosure protocols so that we can meet those very diverse personalized needs. We then asked participants about perceived risks of biomarker disclosure. Again, open-ended question, list, and then asking them to choose the primary risk or the primary barrier, the thing that would stop them from wanting their results. And these are the results here. Now, what I hope you can see is that, again, there are some people that list the concerns that I think we sometimes have as clinical researchers, like there's no treatment, so maybe this isn't actionable, or concerns about anxiety or worry. That was a very, very small percentage. The vast majority, so over 4/5 of our sample stated that there was no barrier, no risk that they felt was sufficient to hold this data for them. So this again really echoes two things. First, that participants and their care partners want this information, but also that there may be a need for really careful pre-disclosure education so that folks, know what they're getting themselves into. I'm really happy to share some of our new qualitative insights from the study. So these are hot off the press. I want to say a special thank you to Mary Lesniak, who is one of my research assistants, as well as Alicia Bergay, who really helped with the qualitative coding here. So I just want to present some very simple data from here. I know it's quite overwhelming on the screen, so I'm going to break it down. So I want to note that the things that are in the blue boxes here are themes that are endorsed by a higher proportion of participants than their care partners. What we saw here were that in terms of barriers or concerns, participants were more concerned about a loss of rights or independence. You're going to take my keys away if I am amyloid positive. They were most interested in disclosure because of the idea of slowing the disease or prevention, as well as knowing more about their personal vulnerability. In contrast, our care partners were more concerned about the potential psychological effects on the participant. So will they become depressed or anxious because of their result? They also cited some significant concerns about their own burden or the changes that they might experience rather than, a loss of rights in the participant. They also noted that they were more concerned or more invested in engaging in biomarker disclosure with their participant because it allowed them to show more support for them and to plan for that support in the future. We also looked at these results by race. Themes that are in these blue boxes were endorsed more frequently by Black participants. And what we see here is that Black participants did note some more concerns about the potential distress that might be associated with finding out that you have a positive result. And I should note, sorry, this is just among the participants. They equally were concerned about a loss of rights or independence. But again, very invested in learning this information so that they could potentially engage in activities that might slow the disease. In contrast, white participants, the one finding that we thought was really most standout for us was that they cited this idea of resilience, this idea that no matter what their result might be, they felt that they would be able to manage it emotionally, financially, practically, physically. And this might speak to this idea of a greater access to resources, for instance. So in terms of answering this question, we know that there is a pretty resounding interest, and I think anecdotally, this is what we notice when we work with our participants. But benefits and knowledge or citation of risks and concerns really vary greatly, which suggests that our approach might need to as well. The next question is how we go about determining the safety of biomarker disclosure. This really falls into sort of two categories. The first being whether or not our participants are really able to make an informed decision about engaging in this kind of health intervention, and also whether disclosure results in significant psychiatric distress. So the way we went about addressing the first question of decisional capacity was by writing a bioethics supplement to one of Dr. Hampstead's R01s with the goal of really understanding if these participants, who in this case had either mild cognitive impairment or a diagnosis of early dementia, presumed to be of the Alzheimer's type, whether they were able to understand the risks and benefits fully before engaging in biomarker disclosure. So this is an ongoing study, but I just want to walk through briefly what we did. So we developed a pre-disclosure education session. This was highly influenced and supported by the Reveal Scan and Scott Roberts, who helped us to develop some of these materials. And in this disclosure presentation, we give some background information about Alzheimer's disease, about what the potential meaning of a PET scan might be, as well as the limitations of what you might find out from your PET scan results. We also talk about the potential risks, including medico-legal discrimination, which is really the primary one, as well as distress and stigma. We also talk about the benefits. And at various points throughout the presentation, we use these checks for understanding that map onto different aspects of decisional capacity, including understanding, appreciation, rationale, and choice. We administered this to participants and to their care partners. We had the participants respond first, and if the participant was not able to demonstrate answers that met our criteria for decisional capacity, we were basically able to then ask that question using a surrogate or shared decision-making model to their co-participant. And if their co-participant was able to work with them and come up with the right answer, then we considered that to be demonstration of shared decision-making or surrogate decision-making. And that allowed them to move forward with learning their biomarker results if they wished to. In terms of results, as we might expect, we saw that in our sample thus far, that individuals with mild cognitive impairment were better able to demonstrate understanding and appreciation, as well as overall disclosure decisional capacity than individuals who had dementia Alzheimer's type. Makes sense. There's, significantly less impaired. They're still independent in most of their decision-making and their activities. One thing I want to note about this was that thankfully all of the participants who had dementia Alzheimer's type or who had difficulty demonstrating decisional capacity were able to recruit a family member or care partner to engage in the study, who were then able to demonstrate decisional capacity, meaning that this wasn't a barrier as long as we used this shared decision-making method to releasing results. This does have really important impacts for clinical care, just in terms of thinking about translating, especially these blood-based biomarkers, into eventually even a primary care setting or a specialty care setting. We have to think about what the most challenging aspects of decisional capacity might be. And here, this study at least shows that understanding and appreciation, so really knowing those risks and benefits and being able to apply them to one's own life, those are the parts that are most challenging for participants to demonstrate, but also the ones that I think we take the least amount of time to really assess properly. The next question was whether biomarker disclosure was actually safe. These are data from that same study that I just mentioned, so the bioethics supplement, and lines on the figure that are this kind of gold maize color are responses from individuals who are what we consider Alzheimer's disease biomarker positive, meaning that they were amyloid positive regardless of their tau status. The lines in blue are those who did not have amyloid. I want to mention that no one in the study thus far has had negative amyloid and positive tau, and that's what we would expect just given the nature of the study itself. So what we did is we do administer some standard questionnaires post-disclosure. This is now done throughout our biomarker disclosure studies. The first is the Beck Anxiety Inventory, which is a measure of distress related to anxiety, or the amount of distress one feels because of different anxiety symptoms. The range is from 0 to 63, with a score of 16 or above, or greater than 16, being moderate anxiety, or really the cut point of interest for us. And what we can see here is that there was a statistically, but not clinically significant difference in anxiety post-disclosure, such that individuals who were Alzheimer's disease biomarker positive were statistically significantly more anxious. But when we look at the scale here, I did blow it up to show the difference, but we're only looking at scores that really go up to about 10, so well below that threshold for clinical intervention or concern. When we look at the geriatric depression scale, we see no statistically or clinically significant depression or adverse events. So I should note that in none of our studies at this point have we experienced any instance of increased suicidal ideation, clinically significant depression, etc. One other note is that we give something called the INI, the impact of neuroimaging. And on that scale, we do see, I don't have it on here. We do see some acute distress that happens directly after disclosure for those who receive a positive or elevated result, but that tends to diminish pretty quickly over time. There's also a really interesting positive subscale of that measure. And one of the items that we like to pull out is whether individuals who've received their biomarker results experience regret. And to date, in all of our studies, we have never had a participant note that they regret receiving their results, which I think is a powerful tidbit. We've begun to go beyond these basic psychological impacts of safety, depression, anxiety, suicidality, to think more about how this might shape a participant's and eventually a co-participant's psychological health. One of the measures we use is the Future Time Perspective Scale, which is a scale that measures essentially how open you feel like the future is and how much control you feel that you have over your future. We didn't see any statistical differences regardless of AD biomarker results in Future Time Perspective. We also assessed self-efficacy for managing one's chronic cognitive disorder. In this case, we used the self-efficacy for managing chronic conditions, and we tailored it for MCI or dementia. Here, greater scores mean a greater sense of self-efficacy. And we did see that this sense of self-efficacy was significantly lower in those who had a positive amyloid result, with most notable differences occurring around the 1 week follow-up time point. We do also look at people at 6 weeks, and we didn't see as strong of an effect. But this does tell us that that's a potential place for intervention in the post-disclosure counseling, is how do we allow people to still feel efficacious and to use this information to empower their activities and plan their activities, as opposed to losing a sense of control. Finally, we administered the stigma scale for chronic disease, which we also tailored for MCI and dementia. This is a measure that really gets a sense of enacted and experienced or perceived stigma from those around you because of your condition. We see that amyloid positive participants do experience an initial decline in perceived and experienced stigma that then reverts back to baseline around 1 week, with the opposite pattern being true. This is an extremely small sample. We think in this case, this is probably a bit of a statistical anomaly as opposed to an interpretive finding, but we're excited to continue using these measures in larger studies so that we can better understand these impacts. So in terms of safety, I think we can say that yes, biomarker disclosure is safe. However, I want to add a really important caveat, which is the for whom. All of these studies use individuals who are psychologically stable at baseline. They don't have severe mental illness. They don't have moderate to high or untreated mental health conditions. And so for that reason, we can really only talk about those groups. Yes, those are the ones who are most often represented in research, but that's not the truth of the broader population. So a big part of these kind of larger, maybe more pragmatic trials with disclosure will have to understand the risks that are unique to other individuals. The next step is really to think about whether this is an effective or efficacious intervention, if we want to consider it that. The question here is whether symptomatic participants understand, so do they comprehend and also remember complex biomarker information. I spent a whole slide telling you how complicated it was to share these results with participants. So we have to know, are we doing a good job at this kind of first pass? So the data that I have presented here, I should note, come from the R03 data. We have not looked at the comprehension results in that STIM plus bioethics study yet, and it is a much larger sample, but we will be continuing to collect those data. What we did in that R03 is after the needs assessment, we used that information to develop our biomarker disclosure protocol. And then we used 10 randomly selected dyads from that first needs assessment to actually undergo biomarker disclosure. And following them, we looked at their ability to recall or understand the information immediately after disclosure, as well as 1 week and 6 weeks later. Here, the elevated group, again, these are individuals who are amyloid positive. The blue line is the not elevated group, or those who are amyloid negative. What we can see is that rote recall of results is slightly higher than understanding of those results. So we split it up here to, can you tell me what your result was? And then can you tell me what the meaning of that result was? And as we might expect, it's slightly easier for people to just tell you my score was elevated or my result was elevated. We also saw this trend towards amyloid positive participants having lower rote recall of their results and more limited understanding over time. This might make sense from a kind of phenotypic standpoint. We don't, it's possible that over time these folks have more significant impairment and that's part of it. But I also think it's much about the messaging. When we're telling someone that they have a not elevated result, it's people feel like it's a very simple message. Whereas when we're talking about the meaning of an elevated amyloid and or tau result, that really is much more complex for people to understand. And I think how they fit it into their clinical picture is quite hard. So we hope to tease this apart with much more kind of direct and detailed questions as part of my K23 and the ongoing bioethics supplement. So the answer here is somewhat. We have a lot of work to do. I think a big part of these kind of iterative piloting of biomarker disclosure protocols is figuring out the best way to share information to a really diverse audience. One of the things we really need to focus on is thinking about graphical representations of risk and how to communicate it in a way that's maybe more interactive and understandable. So in terms of, impact and utility, this is really where my work stands now and where I'm really excited to explore more. We need to understand better how participants and their family members actually use these results. So if they understand them, hopefully, what's the next step? What does it mean for them? What are the downstream positive and potential maladaptive or negative effects of an early etiologic diagnosis? The follow-up step to that will be thinking about the moderating and mediating factors. For me, that's really thinking about how social determinants might play a role in predicting who most benefits or who has the most challenges post-disclosure. And then finally, as we think about biomarker disclosure growing and being disseminated and implemented across different sites, which it really will likely in the future, again, especially with blood-based biomarkers increasing access. A huge question on my mind is that of cultural sensitivity. Okay, so I want to just maybe here introduce my K23 study. We don't have data to show quite yet, unfortunately, but we did start recruiting just last month and we're really excited. So to talk about this study, the goal here is to focus primarily on Black and white older adults. These are folks who are primarily recruited through studies through the research program on cognition and neuromodulation based interventions, as well as other studies that are affiliated closely with the Alzheimer's Center. So again, huge thank you to those centers and those organizations for your support. These individuals have already undergone extensive neuropsychological evaluation through our annual evaluations, as well as PET scans for both amyloid and tau. These individuals are block randomized, and that's stratified by race. And they will receive one of two interventions. The first is a traditional neuropsychological feedback visit, where we go through and talk about their cognitive strengths and weaknesses, their research diagnosis, and some basic health and lifestyle recommendations that we might provide. The second group receive that information enhanced with their biomarker results. So we integrate the biomarker results and what that might mean. When we initially wrote the grant, it was just this parallel groups design, but that was many, many moons ago. And the ethical landscape has really changed since then, particularly because of things like aducanumab and lecanemab. Now there's much greater need, and we're moving rapidly towards this kind of standard to release these results, at least to symptomatic individuals who may be able to benefit. And so we have implemented a delayed start or waitlist control design where individuals who are in that group A are actually eligible to receive their biomarker results, not by the end of the study, but by after their 6-month time point. So we do collect some preliminary data on the two groups being separate, but then we do release their results. And we felt like that was just an ethical need. So after this disclosure occurs, we do follow individuals at 6-month intervals for 2 years. And here we're looking at a range of behaviors or outcomes that include health behaviors, again, things like diet, exercise, substance use. We're looking at their advanced planning, so long-term care insurance or health insurance, placement, assistance from others, durable power of attorney, estates, etc. We're also following their research engagement. So going back to that initial study that I presented from Jen Lingler, does this really enhance recruitment or retention into the Alzheimer's Center studies? Do they engage in brain donation? Are they retained more in these studies? And because we are particularly interested in looking at this from the angle of health disparities, we're also evaluating whether social determinants mediate this relationship. We're looking at culturally competent healthcare access as a more kind of proximal social determinant, but also looking at neighborhood disadvantage as one potential way to look at a more global measure of social determinants of health. So stay tuned. We hope to have some results pretty soon from that study. But the last thing that I mentioned was, with so many teams really across the country and all the different Alzheimer's disease centers thinking about what information to share, a big opportunity presents itself to think more about cultural adaptation. So rather than using this one-size-fits-all protocol that we now know from our needs assessment probably won't work, how do we go about adapting biomarker disclosure to increase its cultural sensitivity? Our goals with this effort are really to enhance not only recruitment into biomarker disclosure studies, including those that we're doing locally here at the center and in the research program, but also to inform the biomarker disclosure practices. So again, this kind of iterative piloting. The broader goal is that we share at the Alzheimer's Center and in our research program, which is thinking about how to build a more sustained, kind of trustworthy reputation within our community. So thankfully, we were able to enhance my K-23 funds through a grant through the Michigan Institute on Clinical Health Research. It's called the Statewide Building Capacity for Research and Action Grant. And I actually just stepped off of a panel right before this to talk about it. I do bring it up because for those of you who are doing human subjects work, local work, and want some additional funds or an additional opportunity to potentially build your community partnerships, they will be publishing that NOA or that announcement very shortly. And it's open to any institution in the state, so it's not U of M specific. So through our SBCRA award, which was a one-year award, our goals were really to go back to participants who had engaged in our biomarker disclosure studies in the past and interview them to better understand through qualitative assessment, rather than the questionnaires we originally used, what they felt like worked well or not so well, what resources they felt would be helpful, etc. We also put together and ran a series of 3 focus groups in which we recruited primarily Black older adults from the Detroit and Flint communities who were very demographically and socioeconomically and occupationally diverse, really stakeholders from different aspects of the community. And we went through in great detail our current biomarker disclosure tools and procedures to get their feedback. I should note too, one of the things I'm very proud of is that that feedback was able to be communicated back to the agreed group of which I'm a part, and back to NIA, which then had an impact on some of the decision aids that we're developing at that national level. So it's shows how community work can really be translated for a really large impact. We also built a community advisory board that was specific to this type of work and specific to our research program. Many of these folks also serve on the community advisory board for the Healthier Black Elders Center of Detroit and Flint, as well as our own Alzheimer's Disease Center community advisory board. And finally, we held a community health event that was really almost totally planned by our community advisory board and by our focus group. So they told us what they wanted to hear about. We were able to put together an educational presentation and a health panel. And again, it gave us another opportunity to really align our priorities as a team with the questions, the messages, the needs that we heard from community members. So I'm just going to throw up a couple pictures of that because it was a really fun event in January. It ended up being a partnership between the Healthier Black Elders Center, the East Side Community Network, which is just an amazing community network in Detroit doing so much, as well as the RBCNBI. But going back to what impact that can have in terms of biomarker disclosure, dissemination, and implementation, I recognize that there is this massive challenge because when we're in a research setting, and really in any setting, we want our empirically supported treatments to be protocolized, to be structured, to be feasible. And that is something that just, in order for us to do this work and get the information back to communities, it has to be feasible. And we know we have finite resources, but on the other hand, we don't think that this one size fits all approach is going to work for every community or every participant. So how do we balance those needs? The solution that I present is by leveraging the power of the ADRC network. We have shared values, shared methods and tools, shared goals. We know now from past meetings and other sorts of priorities published by NAC that this is a major priority. In fact, I'm very happy to say that we finally have a biomarker disclosure best practices and guidelines work group. We're hoping to, we are in the process of developing those guidelines, and we hope to present them at either the spring or the fall meeting this year. But we have this great opportunity to share our knowledge in a way that other networks potentially cannot. So at the local level, we do plan to begin addressing this idea of dissemination and implementation through potentially an admin supplement this spring that we're going to be working on soon. We've also already started building partnerships with other Alzheimer's disease centers that, our goal is really to help them build up their feedback infrastructure and also collect data from them about feasibility, about needs, as well as pilot data that might help us understand how to go about starting cultural adaptation. Now, that's a long process and it involves all the same community engagement steps that we engage in here. And some centers are not at that point. So one of the things that we've started to do is develop and share what we call the Return of Results Toolkit. This is my opportunity to shout out Teresa Gierzinski. I'm sure many of you know her very well, but she has been so fantastic, along with Haley Cole, our research assistant, in really piloting the Return of Results Toolkit here and then helping with dissemination at other sites. So we're working with the South Texas ADRC, with the New Mexico P20, with the Cleveland Clinic Vegas site, and hopefully we just got a note from a few other sites who are interested in practicing or using our resources. To show you kind of a preview of what this Return of Results Toolkit contains. This is a boring list. I'm going to show you the pretty slides instead. We have examples of how we go about introducing feedback at our site. This was something that was generated by our ORCOR and clinical core together. We have some slide decks that are relatively templated that, again, we've tested some of the comprehension and understanding of these. We have some health education slides that can also be used as part of the disclosure process. We have report samples, editable templates. We also, I want to say that ORCOR does such a fantastic job of producing some of these single page fact sheets, and reinventing the wheel doesn't make sense. If these are things that we can share as a resource from our center to others, that's wonderful. We also have at least examples of some of the localized work that we've done to build up lists of very specific resources that participants might want post-disclosure or post-neuropsychological test feedback. Now, these are geographically specific, so they won't translate perfectly over to these other sites, but they give an example of the amount of work, honestly, that needs to be done on the front end to prepare for disclosure. John Reeder, huge shout out to you and your team for helping us with the REDCap data integration. REDCap is being used by all of the sites, so that really allows us to capture data from the sites on feasibility, on how their feedback process is going, as well as some information about our focus groups and other types of data collection we'll be doing. And we're hoping to really continue to build this up and have a biomarker disclosure toolkit that really integrates information that, yes, is freely available on websites like Adore and the Agreed website, but really hasn't been kind of brought together for the use of the Alzheimer's Disease Network. So in summary, I want to emphasize that the return of individual research results, it might be an important tool for recruitment and retention of those diverse cohorts that we care about. We really want representation in research, and this might be one avenue to achieve that. But it isn't as easy as just saying everyone gets their results. While interest in results is near ubiquitous, the reasons for wanting their research results, the reasons for not wanting that really are very diverse. And that means that we have to slow down and think about how we adapt this to be tailorable. We have learned thus far that shared decision-making around disclosure is extremely important, particularly when we're talking about individuals who have cognitive impairment, but also because we know that these decisions don't exist in a vacuum. The effect of learning one's biomarker status is not really just personal. It's on care partners, family members, community members. And so a shared decision process is probably important. The disclosure is largely safe for cognitively symptomatic and asymptomatic individuals who are stable at baseline, but more work needs to be done to understand how, the average participant that we see who may struggle with anxiety or depression might respond to this kind of information. We have a lot of work to do to boost comprehension and not just recall. A big part of that is thinking about, as we develop new biomarkers, new sources of health information or risk information, how do we take an actuarial approach to integrating this information into a message that is meaningful and understandable for the average audience? It's a hugely complex task and needs a lot more work. Little is known at this point about long-term adaptive or maladaptive trajectories following biomarker disclosure, and we hope to begin to address that in the next few years with MyK. And finally, collaborative, community-engaged approaches are what's needed for cultural adaptation. And I really appreciate everything that Ben has done and Hank has done and others, Scott, Irving. I think we have a lot of voices here who are really proponents of community-engaged practices, and that needs to continue in this space as well. So with that, I'm going to stop. I do just want to acknowledge certainly my funding sources, but most of all my participants and their families, because they trust me with some of the more vulnerable moments of their lives. And I think that speaks volumes of you know, the need for relationship building. I want to thank my mentoring team for my K, who are also many of them my former rec mentoring team, and my wonderful lab, who have been working very, very hard. Quick shout out for Mary Lesniak, who's going to be looking for a new research assistant position. If anyone's looking to hire, she's amazing. Sarah Feldman's our dissertation student, and she will also be shortly looking for a postdoc. So let me know. I am on Twitter. Feel free to tweet or retweet or message me, and I'll also take questions over email and now.
Hi, Annalise.
Hi,
Great job, like always. A lot of information there. I wanted to ask you, because one of the important impact that you have made, starting to make already, is how they can be implemented in other places and uptake by other ADRCs and beyond, right? Have you looked at, let me put it this way, another component of receiving the feedback is who gives the feedback. And there is a challenge. It is a challenge, but it's also an opportunity to diversify the research teams so that our research participant members of our communities feel identified within the research team and maybe better receptive to the feedback and the information that is needed, the information that we can deliver so that they are better informed. So have you evaluated, for example, different dyads, but not dyads in the context of participant and co-participant, but participant and research team member, meaning they are the same culture, the same language, the same, that kind of aspect?
I mean, you said it so well, Irving. It's, one challenge is also diversifying the pipeline into this field and the representation within our teams. We know that match, it isn't necessarily about a racial ethnic match or language match. A lot of it is about cultural competence and balanced with cultural humility. So while I think it is incredibly important to, again, work on improving that pipeline so that we get greater diversity on our research teams, it's also about training our research teams to have adequate cultural humility and therefore partner with our communities as the experts and let them be the experts in guiding how we do this. I want to provide, so to your question, our clinical core here have been evaluating, even just in our annual evaluations, they've been doing a post-evaluation survey that tells us about perceived competence of the team members you worked with, perceived comfort level or satisfaction. And then post-disclosure, we recently started, we have both a study that looks at neuropsychological test feedback within the center and also in our biomarker disclosure studies, we do assess things like satisfaction that could be looked at by the kind of cultural match or mismatch. But I want to provide just one quick note because I think this is such a great comment. Perfect lesson that we learned. We've been partnering with the New Mexico ADRC. They've been beginning to implement some of this return of results toolkit. And they immediately, one of the first things that we did was just to take the toolkit to their community advisory board, which are primarily individuals who are American Indian, indigenous, coming from the Pueblos. And there was a very instantaneous, before we even talk about receiving these results, who would be giving these results? And is there a way for the results to come from one of our trusted community members as opposed to the clinician? Alternatively, we are less concerned about personal results and more concerned about community level results. So these are the types of things I think this is where those opportunities to engage in your community will be really pivotal in figuring out how to go about tailoring biomarker disclosure. So yeah, great question.
Actually, there was a something that surprised me too in talking with the Dementia Minds members, that they feel better if there is someone with them that also have been diagnosed as a peer when these things happen, that somehow they build a sense of community between them that actually strengthen their views about participating in research and maintaining their and retaining in that research process. So having a peer that is there with them and they're supporting each other throughout the process. So that was very interesting to learn.
I think that's so true. One of the very few silver linings of the pandemic was that it really shifted a lot of what we do virtually, which has allowed us to really include way more people in the disclosure process than we initially expected. So we've had disclosures where we've had, someone's pastor present, someone's certainly adult children from across the country, someone's community, community advocate or community friend. So I think that that's a great point. Look and see in the chat. Any other questions?
Hi, Dr. Rahman. I do have a question. Thanks so much for your interesting talk. This is really fascinating and just really excited to see all this great work that you're doing. So I do have a question. I think it's sort of related to Irving's question. I'm wondering, you talked a lot about doing various types of community engaged work, but it looks like right now a lot of it is through the use of qualitative interviews and mixed methods research, and then on the back end or later end you do some work with community advisory boards and so forth. There's been some push in other areas of research to actually insert community members pretty much just on the very front end of the research. So right during the design phase where you're designing your qualitative interview questions, and maybe even having a community leader who's a member of the team. And I think this might actually resolve things like peer support and things like that down the line. So I'm just kind of wondering, for your future research perhaps, or maybe you're already doing this, how you might think that could fit into your own work.
Thank you so much for that question, Michelle. That's, I think, as someone that was kind of classically trained as a neuropsychologist, even the qualitative part was very, very new to me. And something that I didn't have expertise in. And so I felt very lucky to be able to kind of take that pause and say, I've done things in the wrong order. Even with the needs assessment for the R03, the intention was to kind of use that community perspective to guide the disclosure. But ideally, we would have started with community engagement at the point of writing that grant. And so this was really this SBCRA award really is very focused on just building your community partnerships and thinking about how do we align those priorities or have equal involvement every step of the way. So as we move forward with these return of results toolkits, a lot of it has been learn from the things that we didn't do so well. And so one of the, in our data use agreement, one of the things that we actually discuss, and when we discuss have these initial meetings with our partners, we do talk about, do you have a community advisory board? And would they be willing to, review this information, sit down? Do you have capacity to conduct focus groups in the way that we did after the fact, to really collect information, again, to think about how these need to be applied. So I talked about, the New Mexico group. That was a very instantaneous shift in our trajectory that we as academics felt like was most important. So I really appreciate that comment. I think that so often we are asking people on the back end, and that's not the ideal way to go. Well, I do see we're at 1 o'clock. If anybody does have any other questions, please feel free to email me. And if you're interested in seeing the Return of Results Toolkit, we're happy to meet with you and chat with you. But thanks, everyone.
Yeah, thank you, Annalise. That was really great. If anybody has time, please fill out the evaluation. And if not, I will see you at the next one. Our next Leaders Initiative meeting is the 24th of April. So we hope to see you all there.